decay, saturation, translucency, failure. We need the integration of these different topics: diagnosis, the relationship with dental lab, procedures, the material selection, the magnification concept, and the meaning of aesthetics. In my lecture today, I would like to share some of my thoughts, some of my ideas about each topic with you. It's not my objective today to talk about the connection, the relationship between these different topics. In my lectures and courses, I frequently ask which impression material I use, which balms I prefer for contouring, how I do a provisional, but I have never been asked about the most important thing, in my opinion, to achieving an aesthetic result: diagnosis. Diagnosis, where do I currently stand? And treatment planning, what is my goal? Diagnosis, where is my starting point? And treatment planning, what is or where is my finish line? We need to know in advance our limits, and these limits to me are diagnosis and treatment planning. Without these limits, without the diagnosis and the treatment planning, we can go about an aesthetic case. Look at this case, Fabio's case, with just 4 restorations. With just 4 restorations in the upper incisors, we can change Fabio's face. We can completely change we can get a completely change in Fabio's look. This, to me, clearly shows the power of diagnosis. Furthermore, we need a multidisciplinary approach for nearly every case in dental aesthetics: orthodontics, surgery, periodontics. How do we coordinate these different treatments? How do we coordinate these different tasks? And who will lead this team? Who will lead this multidisciplinary team? The answers to these questions are key in diagnosis. And finally, the precise observation of details. Look at this lateral incisor in this full mouth rehabilitation. Look at the differences between the initial and the final situation. Small differences, a lot of small differences to get a maximum effect in the end. The precise observation of details, the details, makes the difference in diagnosis. Other topic, material selection. Which material do we choose for our restorations? Which material do we choose for our indirect restorations? Look at this photo. Look at this case in the recall after 6 years. We can see a nice layering inside the edge, a nice surface texture. When I ask the dentists attending my lectures about this case, they tell me, I like Rafa, I like this case. And I think, if I post this picture on Facebook, I will get a lot of likes. Look at this now. Better or worse? Poor surface texture, poor layering, sisal edge, if I post this picture on Facebook, not even my best friend will click on like. And when I see this photo, my first case, my a lot of likes on Facebook case, I can see, and when I see a Pablo with my own eyes, I can clearly see the main problems in dental aesthetic rehabilitation today. Oversized restorations, the restorations are too big, and excessive value, problems with the value. And when I see this other photo, and above all, when I see Atalia, my patient, with my own eyes, my eyes cannot tell me if Alia has any restored teeth or her teeth are natural. And this is because the light behavior is the same in the restoration and in the natural tooth. And I don't care what I can see in photos. I don't care what I can see in this photo. And I don't care what you can see in photos, because the only important thing to me is what these two, my eyes, face to face, tell me. A veneer magnified 50 times. We have different materials. We have image press and image serum. We have different materials with different optical properties to match the natural tooth. If we think in aesthetics, a natural tooth is shade, saturation, translucency, value, and fluorescence. If we have a material with these optical properties, then we don't need a blend of different materials to match the natural tooth. In my opinion, such material already exists, IPS image press. Under any kind of light, the lay behavior is the same. With just a correct shape and contour, our restorations will be invisible. For this reason, I use this material and this technique, the staining technique, for all my indirect restorations, like in this case, a central upper incisor, for inlays, onlays, and crowns. Of course, for the veneers, look at this incisal edge with staining technique, without layering technique. And I use the layering technique only in this case, in the upper central incisor in very young patients. Other topic, dental lab. The relationship between dentists and dental technicians has been, and still is, a very discussed topic. I have here a lot of discussions in a lot of lectures and conferences about this topic, but there are issues that I have never heard talk about that, in my opinion, are important. If my wife lives in the USA and I live in Spain, no matter how many emails I send her, no matter how many phone calls or how many Skype dates we have, what kind of relationship will that be? What kind of relationship would that be? And I hear We don't have time to have a meeting with our dental technicians. What? We don't have time for what? We don't have time to have a meeting with the most important person to achieve an aesthetic result. With indirect restorations, we don't have time to have a meeting with this person, with the most important person. What are we talking about? Are we talking about health? Are we talking about dental health? Or are we talking about business? Are we talking about the dental show business?